So it's with great pleasure that I'd like to introduce Dean Bruce M. Koeppen, MD, PhD. Dr. Koeppen received his MD from the University of Chicago Pritzker School of Medicine and his PhD in physiology from the University in Illinois. He completed a research fellowship at Yale University, where he joined and then went on to join the faculty at the University of Connecticut School of Medicine, where he served as a professor in the departments of medicine and cell biology, and there he was dean for academic affairs. The most exciting thing that Dr. Koeppen, I think, has probably done academically is he joined Quinnipiac University as the founding dean of a new medical school in 2010. This is the Frank H. Neja School of Medicine. In everyone's programs, you'll have a flash drive. On the flash drives, we have everyone's presentations. But I've also included this document from the Association of American Medical Colleges. It was a document that is basically, there was a study that was funded by the Macy Foundation, and the AAMC supported a grant, a 4-year study titled Learning from the Experience of a Consortium of New and Developing Medical Schools. And in his career, Dr. Koeppen was telling us that he has been able to advance curricula at the University of Connecticut, but he essentially had a fabulous job to actually create a medical school from scratch with all of the knowledge that you had, previously, that we all contain. It would be a dream come true if we could just say we're just going to start a new medical school and we're going to do everything perfectly right. I'm sure it was a dream come true. I'm sure you had no challenges whatsoever. So it's very, very exciting. I actually put the topic down as Medical Schools of the Future, and it's with great pleasure that I introduce Dr. Koeppen to talk.
Thank you and good afternoon. In case you haven't heard of the Frank Neja School, it is a school within Quinnipiac University, which is located in North Haven, Connecticut. And what you see is what we refer to as the Center for Medicine, Nursing, and Health Sciences, because we've co-located those 3 schools within this complex. What I'm going to do today is simply tell you a story. I have no financial or other interest to disclose, and my objectives are pretty simple. And to help you understand the process that we use to design a curriculum where none had previously existed, as well as the product of that process. So I will describe the curriculum that we are currently implementing. Also, I want you to understand the importance of faculty development, not just for curriculum development, but for ongoing quality of teaching and curriculum evolution. My outline, I'm going to give you a brief history of the school. I'll then give an overview of the curriculum and its development process. I'll speak a little bit about faculty development, and then I'll end with some of the outcome measures. We don't have a lot because we're pretty young, but I'll share with you what we have to date. So, brief history of the school. In December of 2009, the Board of Trustees of Quinnipiac University approved a plan to start the school. I was fortunate to be appointed as the founding dean, and I began on November 1st of 2010 with a charge from the president to build the medical school, admit the first class by fall of 2013. We didn't even have the building at that point. By January of 2011, I had my senior leadership team on board, and we hired our first faculty member in May of 2011. We started out with 20 founding faculty for the inaugural class, and I'll say more about that in a bit. In October of 2012, we were awarded preliminary accreditation, which allowed us to finally recruit students. In August of 2013, the inaugural class did in fact start. We had 60 students in that class. In February of 2015, we have achieved provisional accreditation, and this past February, we were awarded full accreditation, and about a little less than 2 weeks ago, our inaugural class graduated. It was quite a celebration. So, how do we build a curriculum from scratch? Well, the first thing was to hire faculty committed to excellence in medical student education and support them with robust faculty development programs. Now, I've stolen this diagram from a book by Dr. Whitman, and it's called The Creative Teacher. And you can see the 4 panels there, and you can impart useful or not useful information, and you can do it in a novel way or a not so novel way. My goal was to hire those 20 inaugural faculty or founding faculty all in the upper left-hand corner. And the way that was done, I will tell you, we did a national ad campaign for founding faculty. We had 1,000 applicants for the 20 positions we were going to fill. None of the faculty are required to generate salary support from external sources. I pay 100% of their salary. In order to get a job on the founding faculty, when they came for their on-campus interview, they were not asked to give a research presentation. They were asked to give a presentation they would give to first-year medical students. We didn't have any students, so I filled the lecture hall with PA students and nursing students, and they evaluated the quality of the presentation. And if they didn't like it, that individual never got a job offer. So I think of the 20 out of 20 of the founding faculty fell into that upper left-hand quadrant of that diagram. Second was to define the school's vision and mission. And our vision was to be a model for educating diverse patient-centered physicians who are partners and leaders in an interprofessional healthcare workforce, responsive to the healthcare needs in the communities they serve. And our mission was to enable medical students from diverse backgrounds to attain their highest personal and professional potential in a collaborative, student-centered environment that fosters academic excellence, scholarship, lifelong learning, respect, and inclusivity. Everything we did from that point on had to tie to the vision and mission. Third, we had to define our educational competencies. We maybe got a little carried away because we came up with 10, and many of those you will recognize. We did put interprofessional collaboration, citizenship and service, medical practice management, and concentrated and independent learning. And again, whenever any part of the curriculum was designed, it had to map to one or more of those competencies, or it wasn't going in. Fourth, and this was probably the hardest, was to create an environment that promotes innovation and listens to divergent viewpoints. So I had some basic rules. Number one, no one, not even the dean, has all the answers. 2, academic rank does not mean you have a louder voice or you're smarter. There is no penalty for an idea that ultimately doesn't work, but having no ideas is not an option. And then rejecting an idea requires data. You simply can't say, oh, that'll never work. You have to say that won't work because of A, B, C, and then you were asked, so prove that A, B, C isn't going to let this work. And then last, whatever we did, we had to pass LCME review. And I just show you a picture. The faculty call this the curricular cove. This is where they met every Friday to bring together the work they had been working on independently. And it was all pinned up on the wall, and the pages could move, and that's the way they started to piece the curriculum together. As we got close for preliminary accreditation, I walked by this curriculum cove, and this sign was placed on the door. LCME Think Tank, War Room. Now that was a little disconcerting because at this time I was still a member of the LCME. But it all worked out. So, what did we build? So this is the 4-year curriculum. The pre-clerkship is shown up above in the purple. They have a 10-week break between their first and second year. The vast majority of the students use that to engage in research or begin their capstone project. And I'll come to that in a bit. We then go into the clinical component of the curriculum, 3rd and 4th year. You'll see it's fairly standard to what you see. There's clerkships and electives. It's just packaged a little bit differently. Our learning formats, we do lecture, but we do not exceed 50% of classroom time as lecture. We do a lot of small group. We do laboratories in anatomy, histology, and pathology. We use problem-based learning. We incorporate journal clubs within this, and we do a lot with standardized patients, both formative and summative. If we look at the pre-clerkship curriculum, this is what it looks like. We have only 3 courses, so it is an integrated curriculum. Foundations of Medicine in the first year looks at the normal structure and function of the human body, and it's organized in organ system format. Parallel to that is our Clinical Arts and Sciences course, which has 2 components: Foundations of Clinical Care, which is basically doctoring courses where the students learn how to interview and examine patients. That's where they interact with the standardized patients a lot. And then we have what we call the Medical Student Home. That is a 2-year longitudinal, if you will, preceptorship. I'll say a bit more about that in a little bit. And so our students start seeing patients within the first 10 weeks of medical school and continues on through the 4 years. Then we have a course that has a very cumbersome name, Scholarly Reflection Concentration Capstone, so we just call it SRCC. And basically, every student is required to work in an area of concentration that they choose, and it culminates with a capstone project. I'll say a lot more about that in a few more slides to give you some of the details on that. And then we have longitudinal themes that weave through the courses. BASS stands for Behavioral and Social Sciences, including global health. Law and ethics and pharmacologies are themes. We have no discipline-based courses. The students get 1 grade at the end of the first year, and it's either pass or fail. Second year, and what I'm showing you is what we are currently doing. In the first iteration, the second year was as long as the first year, and we truncated it, and we moved taking USMLE Step 1 from at the end of the second year to any time during their third year. They get to pick when they want to do it. And the same 3 courses run through the second year. The one difference is that Foundations of Medicine now is looking at diseases across the organ systems, and most of that is delivered through problem-based learning. Here's just an example of a 1 week in the first year. And it starts out on Monday with some clinical vignettes. And these happen to be a motor vehicle accident, sickle cell, and G6PD. Then they have different sessions. Some are lectures, some are small group. As you can see, the focus of this week was on blood, hematology. So they have public health, the burden of hematologic disease, global health, worldwide impact of iron deficiency. They have their exam in their Foundations of Clinical Care is taking a history and examining patients with anemia. They're going to their medical student home. They are placed with a primary care physician in the community. That community was told that in this week, if you have any patients with anemia, make sure the student gets to see them. And then the journal club is on iron deficiency anemia. So we try to bring topics from multiple disciplines together in a very integrated manner. I show this one because this was a week where it really came together nicely. They're not always this coherent. Here's an example from the second year. And it starts out on Monday morning with a PBL case. In this case, it was a non-ST elevation MI. They do PBL Monday, Wednesday, and Friday mornings. And then they have small groups and lectures around that. They have the pathology, now congenital heart disease. In their Foundations of Clinical Care, they're refreshing their understanding of the heart and lung sounds in what we call advanced CV and pulmonary physical examination. And then in the medical student home, again, The preceptor is told if you have any patients that have issues, cardiac issues or respiratory issues, this is the week to make sure that the student gets to see them. So let me tell you about this medical student home. As I said, it's a 2-year longitudinal preceptorship. Students are placed by week 10 of the first year in a primary care physician office. We have given them basic clinical skills up to that point so that they can actually function in the office and not just simply be a piece of furniture standing in the corner. The objectives of this experience is for the student to observe and understand the progress and management of chronic diseases, to be involved in the provision of continuity of care, observe and understand office management, and we hope and hone their clinical skills, and what we hope most of all is that they form a very strong mentoring relationship with this primary care physician. It's one of the highlights of the week for the students. The Scholarly Reflection Concentration Capstone, or SRCC, is a 4-year course, and it has certain themes that run through it. There's a theme of epidemiology, medical informatics, and biostatistics. Narrative medicine is included in this. They have their concentration and capstone experience and a lot of mentoring. In the first semester of the first year, that's where they get a big dose of epidemiology and study design. I call it, they're building their research toolbox. They're given all the tools they would need to design a research project on their own. In the second semester of the first year, they have to declare an area of concentration that they're going to work in. And we've built these in cooperation with the other schools at the university. So the Global Public and Community Health is based in the Institute for Global Public Health, which is actually part of the medical school. We have a health policy and advocacy concentration developed with the School of Law. Health management and leadership is in the School of Business. Health communication is School of Communication, and that's where the gaming division is. So a lot of the students are doing medical apps for smartphones for their projects. Medical education, we work with the School of Education. And then translational, clinical, and basic science research is pretty much housed in the School of Medicine, although students have mentors outside of the university. And then finally, medical humanities with the College of Arts and Sciences. So at the end of the second year, they've picked their area of concentration. They may start their project in that summer between their first and second year. Some do, some aren't that advanced yet. In their second year, they take courses in this other school. So they're taking law school courses, or they're taking business courses, or whatever that relates to their capstone. And then they can continue their capstone through their third and fourth year. They don't have a lot of time in the third year, but as you'll see in a moment, we set aside enough time in the fourth year where they can finish up their capstone. And they had some magnificent capstones. And every diploma is customized. So that it will say so-and-so awarded MD with distinction in global public health, or with distinction in health policy and advocacy, so that they have a record of this work that they have done for 4 years. While it's part of the curriculum, it's really, I call it co-curricular, because it is completely student-driven. And I tell the students, if you don't like your project, you have no one to blame but yourself, because no one picked it for you. Here's what the clerkship and clinical elective curriculum looks like. We have 6-week standard clerkships in the third year. You can see what they are. The flex week is where the students, we don't own or operate a hospital, so we have a lot of partners in the community. So we bring everyone back to the North Haven campus. We do some special topic teaching. We do a lot of OSCEs during that time that tie back to the clerkships that they're doing. And then they don't take them in this order. They plan their third year in the order they want to take it, and they can put USMLE Step 1 right at the front end, or they can put it at the end as I've shown here. They can put it wherever they feel most comfortable doing it. And they get 6 weeks off to prepare and then take the step 1. They immediately go into the 4th year, and again, it's up to them to schedule their step 2, both clinical knowledge and clinical skills. They've got 8 weeks to finish up their capstone. They've got required rotations in emergency medicine, critical care medicine, and then sub-I that they choose, and then the rest is all elective. Again, that can be programmed in any order that the student wishes to program. That very briefly is the curriculum. The process was an iterative process. I can tell you that during that first year, we were basically 1 week ahead of the students in terms of getting everything ready to deliver. And then the fact, when you only have 20 faculty, full-time faculty that have to teach both the first and second year, when I hired them, I said, if you take this job, understand you will be required to teach out of your comfort zone. Okay? You may be a biochemist, but that's not all you're going to teach. And so faculty development was absolutely critical if we were going to pull this off. Okay? I had really good teachers. They were really comfortable in the area they had been teaching for a long time. But now they were told, well, you're also going to teach this, and we're going to help you do that. I believe any faculty member in any medical school, if given the resources, given the time, can teach anything at a level that's appropriate for a medical student, whether they're a first or second year. And that's what our faculty development was based upon. The very first associate dean I hired was an associate dean for faculty development. That's how important I felt that was to our success. We have a faculty development policy. Every faculty member must complete 4 hours of School of Medicine approved faculty development during the first year in which they are a faculty member teaching students. And then every year after that, they have a 2-hour per year requirement. And again, we have a very distributed clinical faculty, and to try to get them together for a sense of family, they have to go at least once every 3 years. They have to attend an on-site faculty development session. We do a lot of online faculty development because of the distributed nature of the faculty. If you fail to meet this requirement, you lose your faculty appointment. Category 1 CME is given for all faculty development activities. And I will say that each time the LCME came to visit us, and it was 3 times in 4 years, yes, I'm glad it's behind us. Our faculty development efforts were cited as an institutional strength. So we have a faculty development resource on Blackboard for all the students. You can see that we have required documents, basically our mission and vision statement, our educational competencies, course objectives, and it has to be read and attested to. There's calendar of live sessions, there's online modules, there's other resources, and they can even track their faculty development credits on the Blackboard website. Just to give you an idea of some of the online modules, these were created by our Associate Dean for faculty development, and we try to cover everything that would be relevant, whether you're going to be teaching in the basic sciences or you're going to be precepting in a clinical setting, giving feedback. We use the city modules. I will say in that SRCC, every student is required to complete the city modules under responsible conduct of research. They will not pass that course unless they pass that entire module on responsible conduct of research. In addition to these, what I'll call homegrown online resources, we've made available to them the Epigeum platform. The reason we got involved in this, if you see down in the kind of the right lower, it says lead advisor, Dr. Lisa Coplet. That's our Associate Dean for Faculty Development. So she worked with Epigeum to develop the, this series of online things for teaching and assessment for medical educators. And so because she is the lead, we actually get it for free. There is a fee if you use this at your own institution, and I don't know how much that fee is, but because she's the lead, we were fortunate to get it for free. Some of the on-site stuff we do. We have these monthly, we call them Eat, Educate, and Exchange ideas. I buy lunch. Someone picks a topic that they think is of interest to the faculty, and they share it. We also use that for those who don't attend the AAMC meeting. Those that do will come back and report back what they learned at the meeting. JITT, just-in-time teaching. This is where people learn how to teach outside of their comfort zone. So the content expert puts together a very extensive, we call it a facilitator's guide for whatever the activity is going to be, and then goes through that with the faculty that are going to teach it, answers all their questions. They have model answers as a way to get them up to speed. And it's worked really well. The faculty are a little skeptical at first, but you talk to them after the session and they said, you know, that actually went better than I thought it would. And now it's more comfortable. So we do a lot of just-in-time teaching sessions. We've offered the Medical Education Research Certificate to any faculty who want it. We do annual course-specific retreats for the faculty in that course. We have brought on campus the IAMC webinars. We've brought Kelly Skeff from Stanford Faculty Development Center for Medical Teachers on site multiple times. We've had PBL and TBL training. I'll say that TBL faculty said, you know, not so great. So we haven't done really any TBL, but we do the problem-based learning. All of our faculty go through sessions on how to write exam question authoring. I was chair of USMLE Step 1 committee. I've written hundreds and hundreds of Step 1 questions, so I have trained all of the faculty on how you write multiple choice questions similar to what is seen on the Step 1 and Step 2 exams. We've had sessions on retrieval-based learning, and faculty can request individual teaching consultations and peer coaching, and we have educators in the School of Education that will come and work with the faculty in that regard. Funding. It always costs something, right? So all full-time faculty receive $4,000 a year to be used for personal and professional development. It must be approved by the department chair, and the funds can be carried over up to $10,000. So it allows them to customize their personal and professional development. Our Office of Faculty Development, the Associate Dean for Faculty Development is 0.9 FTE. We have a full FTE program coordinator, 0.25 administrative assistant, and the annual budget for this current fiscal year was $173,000. I think a very modest investment for what we get for that money. Yeah. Dean's Office funds for faculty provides funds to attend National Faculty Development Workshops, AAMC, Harvard Macy Institute. We've sent, I think, 2 faculty for the month-long Stanford Faculty to the Faculty Development Center for Medical Teachers, all funded by the Dean's Office. And we just started this year a grant program for grants for innovation in medical education. So outcome measures, that we don't have a lot. USMLE Step 1, we have a 99% institutional pass rate. And I don't remember the numbers. All I can tell you is that the mean for the class is slightly above the mean for the nation. I don't care a lot about the score. I know the students do because they think it's going to get them that residency. What I care about is that they've passed. In terms of CK, we have a 100% institutional pass rate. And again, the performance is slightly above that of the national cohort. In terms of CS, 100% institutional pass rate. And lastly, we just had our first residency match, and we had 100% match. I purposely tried to keep this short because I anticipated a lot of questions. And so I'll just leave you with another view, a little history on this building. This was the former headquarters of Anthem Blue Cross. And the university purchased this property in 2007 for $32 million. And it is 104 acres, 4 buildings of about 600,000 square feet, and what you can't see because it's behind there is a 1,300 car parking garage. Anthem, as they moved out in stages, Quinnipiac came in and gutted the building and rebuilt it for educational use. I had the great fortune of designing the building, not by myself, but I worked with the architects. It was probably the most fun. The amazing thing was that they gutted the existing structure, and it was nothing but concrete slab, steel girders, the outside skin, and the roof. HVAC, plumbing, electrical, all gone. And then it was built back in less than a year. And so when I started on November 1st of 2010, I was the only employee of the School of Medicine. I had to hire a leadership team, hire all the faculty and staff, develop all the policies and procedures, get the school accredited, recruit the student, build the building. And we got it done so that the students walked into that building on August 6th, I believe it was, of 2013. So I'll stop there and entertain as many questions as time will allow. I will say that building the medical school, I've been in academic medicine for a little over 35 years. This has been the most fun I have ever had. Thank you.
Thank you so much, Dean Koeppen. Do we have questions?
Could you just describe for us, please, the gross anatomy, laboratory arrangements, and how that course is structured in the curriculum?
So our faculty strongly believe in hands-on dissection. So on the 3rd floor, we have an anatomy suite. It has 48 stations, 48 cadavers, 4 students to a cadaver. We are a paperless medical school. We give the students all of their textbooks in an electronic format. We use a company called Vital Source, and they will digitize any textbook that the publisher allows, and they can use it on 3 devices simultaneously, even their cell phones. The nice thing is, our licensing agreement, if a new edition comes out, it's automatically pushed to the students, and they get a little notice that the new edition of Harrison's is available to download. And so in the dissection area, there are 2 flat screen computers at the head of each table, and that's where all the dissection material comes up. And the other thing, the School of Health Sciences has a diagnostic imaging program, and on campus we have an imaging suite that contains a 64-slice CT scanner and a 1.7 Tesla open tube MRI that we get to use. And so we scan the bodies as they come in, and the students can pull up the CT and MRI images of the body that they're dissecting. onto those screens. All exams are computer-based. We use national board question banks to give them the feel of that. The Wi-Fi in that building is incredible. It will support 16,000 simultaneous users.
Do you have an attached hospital? Now the other thing is, if you have only 20 full-time faculty, and when the students get out into the community, are those community-based physicians also kind of trained by you?
So we do not own or operate our own hospital. We have 11 affiliated hospitals. Some have had experience with medical students before, others have not. So a lot of faculty development is targeted towards those individuals, and that's another reason we have so much online faculty development, because we have to make it easy for them. And they are all volunteer. The only faculty I pay for, we now have 26 full-time faculty. Those are the faculty that I pay.
So they give the didactic sessions, and then the students go out to the community.
And they get didactic sessions at their sites as well, by the clinical faculty.
And those are voluntary.
Yes, those are voluntary, although they keep hinting they want money. Yes?
That was great. Can you talk more about the quality control of the capstone projects in terms of how does everybody get distinction at the end? Is this a required component of the curriculum? And how do you quality control to make sure that before graduation, everybody has kind of achieved a certain?
So the students are required through a portfolio system to constantly update where they are in their project. They have two mentors. One has to be a School of Medicine faculty member. The other can be a law professor or someone in the business school. But there's certain milestones they have to meet, and that's monitored through the portfolio system. Everyone will get a diploma that says distinction in what their area is. Those that do an exceptional job, theirs say with high distinction in. So I think out of the class that graduated, I think we had 16 with high distinction. And the one that I thought was absolutely phenomenal, and I'll tell this story quickly. She was an artist. And when she heard that there was going to be a Frank Netter School of Medicine, she was going to be a medical illustrator. She said, I would like to go to that school. So she applied. It was the only school she applied to. And she said, if I get into medical school, forget the medical illustration, I'm going to become a doctor. So she got in, and she paired up with one of our faculty who was a forensic anthropologist. So for her capstone, she took the current methodology for reconstructing a human face from skull remains, and revised it, and then solved a cold case in Connecticut. They had the skeletal remains of a woman that was murdered in the 1970s. They were never able to identify. She took the skull, applied her technique. It was on the news, it was in the newspapers. Family said, we know who that is. And they confirmed it through DNA testing. She got high distinction.
So, Dr. Koeppen, congratulations on your success. Can you tell us a little more about your faculty? So, you have 26 faculty in the School of Medicine. How are they evaluated when they go out for tenure? Are they evaluated primarily on their teaching, or do they all have research labs? Do they need to have funded research? Given that this is a new School of Medicine, what is the faculty morale? Are they all as excited as you are? Thank you.
Yes, and they're also tired. The typical profile in terms of how the faculty spend their time. Right now, it's 70 to 75% in education. And that is either in the classroom or preparing to teach. 20 to 25% for scholarship. And scholarship is defined very broadly, and they get credit for it. And some faculty have chosen for their scholarship as curriculum evolution. And so, and then they're, with only 26 faculty, we probably have as many committees as you do. So everyone's on multiple committees. So there's a service requirement as well. When they come up for promotion, the decision is based on the weighted buckets that they spend their time. So we've had, what I did tell all of the faculty when they were first hired, that for the first couple of years, they would have to devote 100% of their time to education, but I would give them credit towards promotion for creating a new curriculum. So we have had a total of 10 faculty promoted so far in our short history. And those full-time faculty are a mixture of straight PhD, straight MD, and two, I think, MD, PhD. So it's a mix.
Do you have tenure?
We do not have tenure. When I started there, I told the president that I didn't think tenure was that important in a medical school. And he argued with me. He said, "You'll never be able to recruit anybody of quality." And I said, "No, I think we can." So what we do is every single person that I hire, every faculty member that I hire, gets an initial 3-year contract. And 3 years is enough time for me to decide if I made the right decision in hiring that individual, and it's enough time for that individual to decide if they made the right decision. They then get a renewed contract. If they're an assistant professor, it's again 3 years. If they're associate or full, it's a 5-year. And those contracts can be renewed and renewed and renewed as long as they do what we ask them to do and it's of sufficient quality. We hired a number of people who gave up tenure at the institution they were at in order to come to the Netter School.
I had a question.
Yes.
About funding.
Funding.
You've made me very jealous. Your faculty development budget alone has made me jealous. So can you please explain how you fund this whole enterprise and how you envision funding it in the future?
So, the question was, how do we fund all of this stuff? So the building of the building and all of the costs associated with getting started before the first student paid $1 in tuition was about $100 million. And that was paid for by the surplus operating funds of the university. So Quinnipiac University was founded in 1929 and has made a profit every single year in its existence. We do not own or operate a clinical facility, and I was told by the president, don't even think of starting a faculty practice. I was also told Quinnipiac University is not and does not aspire to be a research-intensive university. You are not allowed to start PhD programs. He said, you are to build a medical school that will focus everything it has on providing a student-centered medical education. And so we are an incredibly tuition-dependent medical school, which took a lot of talking with Dan Hunt, talking him off the ceiling when I told him what percentage of our revenue was going to be coming from tuition. And what won the day is I gave him 2 spreadsheets of 2 fictional medical schools, both of which were spending $20 million on medical student education. But one of them had a huge hospital. And so they had all these clinical revenue, but they also had the clinical expense. They had a huge research operation. They had all this money coming in, all this money going out. So they had 1% of their total revenue was coming from tuition, whereas the other medical school was kind of like ours. And it had, I think the model I gave them, it had 40% of revenue coming from tuition. And at the time, Dan said he would never accredit a medical school that had more than 10% of total revenue coming from tuition. We're at 50% right now. Okay? Yes?
Do you have departments, like
So we have one basic science department. We call it the Department of Medical Sciences, and that houses our 26 full-time faculty. One department. We have clinical departments, and they are currently based at St. Vincent's Hospital, which is in Bridgeport. Yes.
For the costume runs for 4 years.
Yes.
So if a student chooses a costume topic the first year and it's not working well, could they change?
In theory, yes. It depends on how far along they are when they decide they made a mistake, and can they get something up and running in the time that's left. Fortunately, no, that has not happened yet. It's gonna. There's no question it's gonna happen, but it hasn't happened yet.
So what do you anticipate you will do if it happens?
Yeah, I can't answer that question. I mean, that's up for that course director to figure out.
Is there any integration between the School of Nursing and Pharmacy, since you're all there together?
So we have a Center for Interprofessional Health Education, and we do a lot of events that bring the students from the 3 schools together. Getting courses integrated is really, really difficult, because the health science and nursing are what I would call a more traditional. You know, you have a Monday, Wednesday, Friday class from 8 to 9. You know, we have this completely integrated thing, and that doesn't work, but we do a lot of events. We do some of the work with the standardized patients in teams as well, with the nursing and others, PT, OT. We even had the ultrasonographers, sonography students in there showing the medical students cardiac ultrasound while the students were listening to the heart sounds on the same patient. Yes?
I just wanted to ask about the integration of the journal club. I couldn't remember whether or not it was carried over into the second year. And do you have any metrics on the benefits of actually integrating journal clubs within that?
So the journal club
What's the thinking behind it as well?
So first the logistic. The journal club only runs in the first year, because in the second year they're taking courses in the other schools. And so, and the journal clubs are really to introduce them into how do you read the scientific or medical literature. And so they're asked questions about, was the statistical methods in this paper, were they appropriate, and things like that. So it's part of that building your research toolbox. Students love it. They have seminars on, as I said, responsible conduct of research. I do some of those small groups, and one of the things we require them in that component to do is go on to the NIH site for clinical trials. And you know, we tell them, you may never do a clinical trial, but you're going to have a patient who says, is there a clinical trial that I can enroll in? And you need to know how to go on to that and find the clinical trials that are available that your patient might want to use. Yes?
I'm just going to ask, sorry, the videographer just reminded me, if we're not speaking into the microphones, we're not capturing the questions. So if you could please, thank you so much. There's a mic right behind you.
Just wondering, what is the stats about MCAT and GPA for your students? And
I anticipated that question, and I emailed before lunch my dean for admissions. If he responded, I can tell you. And he didn't respond. So, what I do know is there's a document that's put out by AMSA. I've forgotten the name of it, but it gives the statistics of the various medical schools. He tells me we're in the upper quartile. That's all I know.
Any other questions?
I will say we get about 7,500 applicants. We're now at a class size of 90, so we get 75 applicants for 90 slots. We had 2,000 applicants for our charter class of 60.
Yes, that was my next question. Do you anticipate an increase in class size, and if so, what's the sort of the thought process of the faculty number to meet up to
So
that?
we are now at 90 per class. And that's why we have 26 full-time faculty and not just 20. The school was built on a business plan that we would eventually grow to 125. The building is built to accommodate 125. We will need to hire more full-time faculty when we do that. The issue is clinical placement sites. Connecticut is absolutely inundated with students from the Caribbean schools. And they are paying ungodly amounts of money to these hospitals. One of the hospitals I was counting on signed a 5-year agreement with St. George's to provide 60 student rotations for 60 students for $4.5 million a year. So we have enough quality clinical placement sites for 90 students. We're not even close to hitting 125. And the president, every time he talks to me, so when are we going to 125? When are we going to 125? It's like a broken record.
Second question I wanted to ask is, what did you find as the biggest challenge when you were implementing all of this? And what did you hear from the graduating students about their experience in terms of what really worked well and what may have not?
So the greatest challenge is the clinical placement sites. And I see that as being our greatest challenge going forward. The rest of the stuff really wasn't that hard. The charter class, graduation was truly amazing. They helped build the school. They helped build the culture. They had no upper class students they could go to, but they became the mentors for all of the classes below them. They gave us constant feedback, and they would say, you know, that really worked well, or boy, you blew it on that one. And so I told the faculty that when we started implementing, they had to be ready to make changes on the fly, that we weren't going to continue with something that was not working well. Most of it worked really, really well. Again, the only real change was to truncate the second year, make it shorter. And that was to give students more clinical time so that they felt better prepared for residency. That was one of the things that they said, we want more clinical time, more clinical time. And I will say that the feedback we've gotten from the physicians that have precepted them, even on the away, they do a lot of away electives. The comments on their clinical skills are off the chart.
Thank you for your comments. You brought up a point that I think that a lot of medical schools are going to be faced with going forward, is finding clinical sites, places that we normally have gone to, and it's not just, this medical school, is all many medical schools, is the influx of students who are coming in from the offshore schools. And of course, they are increasing their numbers, et cetera, and they have the money to pay. Using your other hat as your knowledge of the LCME and all that, has there been any discussion about sort of lightening the requirement about allopathic medical students not being in the same facility as the students who are not U.S. medical students?
So the LCME doesn't have that restriction. That's a misperception. Unless they've changed it since I left. But for the 6 years I was on the LCME, I chaired the standards subcommittee.
So it's been in the past, it was considered citation worthy. I guess that was more than 7-8 years ago. So now that no longer is.
To my knowledge, it's not. It's in the same facility, certainly not. They may give you some grief if they're on the same service.
Right, that's what I'm speaking about, same service. So
Yeah.
I know that still exists.
Yeah, that they don't like.
Okay. So is there any talk about trying to lighten that or anything?
So we are sending students to hospitals that have some offshore students, but they're on separate services.
Okay.
Are there any specific courses that you require of incoming freshman students to have taken before matriculating?
Just the standard prerequisites that most every medical school has. We have not added any prerequisites to those.
And
So
you-
biology, chemistry, math, those kinds of things.
so there's not been a disadvantage because Dr. Weiner or somebody, the previous presenter was saying that biochemistry was an issue for their incoming students when they came in.
So we've got a great biochemist on the faculty. And they get, in my opinion, they get more than enough, maybe even too much biochemistry.
How about microbiology?
So I have an exceptional infectious disease individual that heads up the microbiology teaching. He was the head of the equivalent of UK CDC.
So one more question, so two questions. I know you have very few lectures, but is attendance at lectures mandatory or?
Lecture attendance is not mandatory. All lectures are recorded, and in the afternoon, and our classes are all in the morning, and in the afternoon, they are posted so that they can watch them, and they're also posted as a podcast because the students like to listen to them when they drive.
And so you had about $100 million to start a school, and 50% is paid by tuition. So is the rest funded by the organization or
Funded by the university
every year?
every year.
All right.
Thank you for that presentation. I just have a couple of questions. What is the gender mix of your inaugural class and the ethnic mix? And what was the average MCAT score?
So I can tell you that it was exactly 50-50 from a gender perspective. And my recollection was that 18% came from underrepresented groups in medicine of the inaugural class. We've gotten better at that. But the inaugural class, you have to our inaugural class, we weren't allowed to talk to a student until we got preliminary accreditation. And we got that in October 2012. Everyone else had been recruiting since July. So we got 2,000 applicants in October, November, and December. And that's what we had, that's where we took our inaugural class from.
Dr. Manani first.
Yes, I have a simple question. How diverse is your student population and the faculty population?
So overall, I think for the students, it's about 28%. And the faculty, unfortunately, is less than that, probably about 10%. And that we have, we're filling a couple vacant positions right now, and I have told those search committees they need to bring in diverse candidates.
Okay, thank you. And in addition, you started with 60 students. How many of them made it to 100% successful?
So 58 graduated. One at the end of the second year transferred to Tufts because his partner was in Boston, and he was, believe it or not, he was commuting from Boston to our campus for 2 years. And he said, I can't do this anymore. And then the other student decided to take a 5th year enrichment year to do some research. So he'll graduate next year. We did not lose any for academic difficulty.
Hi, this is a financial logistic question. What is the tuition fee, and do you give scholarships to students who are eligible and they need to go to the college?
So by board policy, the tuition of the medical school cannot exceed the median for private medical schools in the Northeast. So we're just below the median. We're about at the price point of Yale. We are allowed to take 25% of gross tuition revenue and make that available as financial aid to the students.
Thank you.
Any more questions?